Hi, everyone. Thank you so much for the opportunity to be a part of this year's FORCE conference. My name is Erika Stallings, and I am a lawyer, writer, patient advocate, and BRCA2 mutation carrier. My co-presenter, Dena Goldberg, will be covering the science of our presentation. So for me, I really wanted to share my journey with hereditary cancer and why it's so important to me to increase awareness of hereditary cancer and genetic counseling and testing in the Black community. Just to give you a little bit of roadmap for today, I will be sharing my personal story and my advocacy journey. And then my co-presenter, Dena, as I mentioned, will actually be getting into the science behind race and ethnicity and the impact that hereditary cancer mutations have on different racial and ethnic groups. So with that, I always tell people that my hereditary cancer journey actually starts with my mom. My mom was diagnosed with breast cancer for the first time in 1993 when she was only 28 years old. Fortunately, because she found her lump while doing a self-exam in the shower, she caught it when it was very treatable and was at stage 1. She underwent a lumpectomy, chemotherapy, and radiation, and then was in remission for the next 14 years. Fast forward to 2007, I am a senior at the University of North Carolina, Chapel Hill, and I find out that my mom is now facing a second breast cancer diagnosis when she's in her early 40s. Now, given her unusual history of cancer, one diagnosis before the age of 30, another diagnosis in her early 40s, and her second breast cancer diagnosis was in a different breast. She also had triple negative breast cancer, a type of breast cancer that's less responsive to traditional chemotherapies. So her treating physician at UNC, which is where she decided to get treated since I was enrolled in school there, recommended that she undergo genetic counseling and testing. And something that I think about a lot, both as it relates to my mom's journey with hereditary cancer, as well as my own journey, is just how much luck and privilege and access is involved in being able to get this information. Before this presentation, I actually went and looked on the National Society of Genetic Counselors website to see if there were any genetic counselors within a 50-mile radius of our hometown, which is Goldsboro, North Carolina, and there's not. So I think about all the time, if I hadn't been a student at a prestigious university that had a really prestigious health center, would my family even know about genetic counseling and testing? But my mom undergoes genetic counseling and testing. She gets her results back, and she learns that she carries a BRCA2. She learns that she carries a BRCA2 mutation. So at the time of my mom's diagnosis with that mutation, I knew that I had a 50% chance of carrying that mutation as well. But given that I was about to graduate from college, move to Washington, DC, and start law school, I made the decision to put off testing for a while. And then I went to law school, studied for the bar, moved to New York in the aftermath of the financial crisis. So even though I had information about getting genetic testing that my mom had packed with me in my suitcase to New York, I kind of kept putting it off. And then finally, when I was 28, which was the same age that my mom was when she was diagnosed for the first time, I made the decision that I really needed to figure out like what was going on with respect to my own hereditary cancer risk. So going back to my point about like privilege and access, I was very fortunate that someone I knew was on the board of a breast cancer nonprofit and was able to refer me to a really great genetic oncologist who does genetic counseling in New York City. I underwent testing and I learned that I had inherited my mom's BRCA2 mutation. And for myself, I think like a lot of millennials, I immediately like went onto the internet because I was really hoping to find examples of patient stories or just resources that could help me put my diagnosis into context. And this was back in 2014, although I don't think things have changed very much between now and then. But when I went online, I didn't find any stories from Black women or even women of color dealing or talking about BRCA1 or 2 mutations or even hereditary cancer generally. And I knew even back then, given the disproportionate impact that cancer has on Black and minority communities, that I couldn't be the only Black woman who was dealing with this type of mutation. And that's actually what sparked my cancer advocacy journey. In the fall of 2014, I wrote an article for Jezebel just about my own experience with genetic counseling and testing, making the decision to undergo a preventative mastectomy, and the impact of really not seeing any other patient stories from women like myself. And that kind of initial article has really grown since then. Over the past few years, I have spent a lot of time both in writing and doing events, trying to increase awareness of genetic counseling and testing, not just amongst individuals in the Black community, but also amongst the genetic counseling and physician community. As Dena will talk about a little bit more in her presentation, I think that there is this persistent stereotype that BRCA1 and 2 mutations are not that common in the Black community, but we know from the research that Black women are much more likely to be diagnosed with triple negative breast cancer, which is associated with hereditary cancer mutations. And we are starting to see some research that indicates that the level of BRCA mutations in the Black community is at least equal to those in the white community, if not higher. But we also know that there are huge disparities with respect to who is getting access and recommendations to genetic counseling and testing. One of the landmark studies in this area shows that even when Black women meet the NCCN criteria for genetic testing, they're 16 times less likely to actually get the referral from their physician. So I'm so honored that Forrest is giving us this time today, because I think it's more than just patient education. I think we also have to do a lot of work to educate the genetics workforce, as well as primary care physicians and OBGYNs, who are the ones who are most likely to have contacts with patients. And as I close out, or as before I get ready to hand things over to Dena, I just sort of want to take a step back and talk about why I think this is so important. If you look at the impact of cancer today in the United States, we know that cancer has a disproportionate impact on Black individuals. Particularly with respect to breast cancer, Black women are more likely than white women to be diagnosed before the age of 50, are more likely to be diagnosed with triple negative breast cancer, and more likely to be diagnosed when their breast cancer is at an advanced stage. Knowledge of family history and utilization of genetic counseling and testing are really important tools for cancer risk management and risk reduction, but currently those benefits are not being fully realized in the Black community. If you are a patient listening in today and you have a family history of cancer on one or either both sides of your family, I really encourage you to start thinking about genetic counseling if you haven't already. I certainly do not want to downplay the emotional impact of learning that you carry a hereditary mutation and the very tough decisions that come with that. But if you're able to get that information, not only are there actionable steps that you can take, it also provides really crucial information for your family members. And if you are a member of the genetics workforce listening in, or a physician or a researcher, I really encourage you to think about the biases, the unconscious biases that might be at play. Think about the recommendations that you're making to your patients. Think about the assumptions that you have about who is interested in genetic counseling and testing. Because the research shows that when it is offered to Black women and the benefits of it are explained to them, they are overwhelmingly enthusiastic. So with that being said, I will now turn it over to my colleague, Dena.
All right. Hi, everyone. My name is Dena Goldberg. I'm a genetic counselor, and neither of us have anything to disclose. Something that a lot of us in genetics and as patients have come across are different misconceptions about who should be offered genetic counseling or genetic testing. So one is that genetic testing is for white people. The other is that the only people who ever come back positive for the test are Jewish ladies. And this is actually taken from a research study and was something that a physician told their patient. And then also my doctor said I don't need genetic testing because I'm Black, Asian, etc. And that is from my personal experience seeing patients in the genetics clinic. So these misconceptions are rampant in this community. Before we kind of dive into everything, I want to really take the time to separate out these words because I think there's a lot of confusion. So ancestry, ethnicity, identity, and race are all complex labels that result from both visible traits like skin color and from cultural, economic, geographical, and social factors. Now, race is often confused with ethnicity or global or geographic genetic ancestry, and race is a social construct, whereas ethnicity refers to groups of people that share some common ancestry, traditions, language, or dialect. So in the United States, race actually started as a social construct based solely on physical features like skin color, and we had white and colored. Those were the first racial categories in the US, and they were really used to give white people power over non-white people. And the concept of race has evolved since then to include a combination of physical features and continental ancestry. But while race and genetic ancestry are separate concepts, they do overlap. Both race and genetic ancestry can affect health, and both can be useful in epidemiological studies when used appropriately. So what is white? Well, white we usually think of as describing someone of European ancestry. People who are European that have been living in the United States for longer probably don't have the same genetic background as somebody who is living in Europe now. A lot of European Americans actually not European ancestry, including a mix of African, Native American, and Asian. And white, by the way, also includes people who are of Middle Eastern, North African, and Ashkenazi Jewish ancestry. Each of these are actually genetically distinct from what we kind of consider this broad European genetic ancestry. So this is not one genetic group. These are actually, in some cases, can be very distinct genetic lineages, but they're all considered white in the US. Now, what is Black? Well, this is typically used to describe somebody with African ancestry. And African Americans in the US typically carry segments of DNA that are actually shaped by contributions of people from Europe, Africa, and the Americas. That mixture is different across the country in different individuals and groups. And so I thought this was a really interesting graph because this graph is showing out of all of these people who have taken the popular ancestry test 23andMe, as it goes from left to right, it's the proportion of African ancestry, but the red are the people who self-identified as European, and the blue are those who self-identified as African American. And you can see that there are people really in the middle who have the same amount of this African ancestry who identified as two different racial categories. And so it shows that there's not really a distinct border or threshold of the amount of African ancestry for someone to identify as Black or for someone to identify as white. So now let's talk about Hispanic or Latinx. And Hispanic really refers to the language. So those who speak Spanish or who are descendants of Spanish-speaking populations. And Latinx refers to the geographic origin, specifically from Latin America. And so Latinos across the Americas have different portions of Native American, African, and European ancestry as well that are shaped by local historical interactions with the migrants brought by the slave trade, European settlements, and indigenous Native American populations. So again, there's a mixture of these different ancestry groups in this broad category. And then there's Asian American and Pacific Islander. In the United States, when we look at the different breakouts or the breakdown of the different Asian groups, so they're all kind of distinct. And so when we think about the way that our genetics mixes, and we think about the United States, those who came here more recently will have less mixture, or usually less of variety in their genetic makeup than those who may have come many generations ago, where there was opportunity for relatives to have children with maybe people from these other groups. there's this assumption that a lot of people make, including your physicians and scientists, that people will usually identify with their majority ancestry. But do they really do that? Well, there's a problem with this self-reported identity. And the problem is that a large proportion of patients cannot accurately identify the ethnicities of their ancestors, especially in the United States. And so there was this study that was done at a major laboratory where they actually asked people what they identified as, and then they looked at their genetic ancestry, and they found that self-reported ethnicity was an imperfect indicator of genetic ancestry, with 9% of people incorrectly identifying their majority ancestry. So that's about 1 in 10 people that believed that they were or identified as a certain ancestry, but genetically maybe that wasn't consistent. And so there are limitations to using this self-reported ancestry. And if we only test people who we believe, who identify as a certain ethnicity or ancestry group, we're going to miss people who are at risk. So frequently clinicians, researchers use this popular notion of race to make guesses or inferences about a patient's genetic ancestry to predict whether he or she carries specific risk factors that influence health. But in order for this to work, first of all, race must correspond to genetic ancestry, which it doesn't, as we've talked about, and ancestry must be predictive of genetic risk, and it's not always. So while race captures some information about genetic ancestry, particularly in the US populations, it actually often fails to account for the mixture and population structure in a lot of these communities and groups. Bottom line of everything I've said so far, a person's race should never exclude them from genetic testing, because categories of race are better suited to discussing shared cultural, geographical, and social factors. And those who identify as being part of a specific ethnocultural group, they tend to share cancer risk factors with others in that group. This is why it can be helpful to ask these questions. But those with shared ancestry, they share some genetic markers with each other. So these are, by looking at all this information together, we can get a better idea of what someone's risk might be. So now let's talk about this cancer risk. And I'm gonna kind of put my genetic counselor clinical hat on and just explain something that maybe a lot of you are probably familiar with already, but when we think about cancer risk, we put cancer into these 3 different categories. One is sporadic, and that's typically when we see a cancer at an average or older age, and it's usually a more common type of cancer. And we believe that these cancers are a combination of so many different factors that we can't really put our finger on one. And then we have this familial category where it's kind of a mixture of environment and genetics together, where we see clusters of cancers, we see average or older ages of onset for that particular type of cancer, and relatives may share risk factors, not necessarily genetics, but other risk factors that may give them a similar or higher risk for cancer. And then we have about 10 to 15% of cases that are hereditary. And this is when we see multiple generations affected at younger ages of onsets, and relatives of these people may or may not be at an increased risk because it's due to a single genetic mutation that gets passed down from generation to generation. So when we think about genetic testing, we're really focusing on this hereditary cancer risk category, because we are trying to see, does someone have a single genetic risk factor that gives them a high or moderate increased risk for a certain cancer. So I wanted to go over some of the factors in cancer risk and development that are maybe more on the sporadic side. So one category would be something like lifestyle behaviors. These are all going to be things that might alter someone's cancer risk. There's socioeconomic factors like education and income level, access to health insurance, and routine medical screening or occupational exposures. There's cultural factors, including people's belief or mistrust of the medical system that may prevent them from having screenings. And then as someone gets older, their risk increases. And also there's genetics that kind of is that last category we were talking about. So if you think about somebody's racial group that they identify with, they may share a lot of these factors in the first of these 3 groups. And then ancestry groups may share these genetic factors. There are some cancers that do occur more frequently in certain populations, which allows us to use these categories to determine if someone may or may not need more screening or intervention. Now, one example is prostate cancer in Black men. So Black men generally get fewer PSA screenings, are more likely to be diagnosed at a later stage, and are less likely to have health insurance and less access to high quality care, and maybe have some other disparities that can be linked to overall socioeconomic status. So it's not necessarily maybe the genetics that are involved, but it's also being as part of this racial group. Another one that we kind of think is an exposure or genetics would be nasopharyngeal cancer in Southeast Asians. So what we know about this type of cancer is that it is a higher risk for those who've had higher salted fish consumption, especially in childhood. There's risk factors like consuming nitrates that are in some foods that are more traditionally used in southern China. The use of traditional herbal medicines has been associated with this, and also occupational exposures to formaldehyde, wood dust, smoke, and chemicals. So these are things that this group shares that may not necessarily be genetic, but are common to this, I guess, racial group or this population. And another one would be gastric cancer in Latin America and Asia. Well, we've done a lot of genetic testing, and yes, there are some genetic risk factors for these people in these populations, but for the most part, they're negative when we do genetic testing. And part of that is because a thing called H. pylori, which is a bacteria that is found in a lot of the food in these countries, and also because of lack of food storage in some of these countries. So we actually have found in general that gastric cancer rates are higher in certain developing countries. And there was a big study that was found that the more access to refrigeration a country or population had, the lower their rates of gastric cancer. So that kind of shows us that there's probably something to do with shared environmental and lifestyle exposures or risk factors. And so these are just some examples of why using someone's genetic ancestry may not always be helpful in determining their risk, because there are these other things that we have to consider as well that we look at from a whole population. So now I'm just going to quickly breeze over this. These are some of the hereditary cancer syndromes, and there are many of them. And we'll go in a second into which ancestry groups may or may not have higher rates of each one. I want to touch on this Jewish comment that was made earlier. If you remember, I showed you the slide that a physician said that mostly Jewish women are positive. People of Ashkenazi Jewish ancestry, which are more recently European Jews, share a group of common ancestors and were socially isolated for many generations. Many Jews married and had children with the community, causing a distinct gene pool, and about 1 in 40 Ashkenazi Jews today carries one of these 3 founder mutations in BRCA1 or 2. And this is 10 times higher than other groups. And this is what gets taught in medical training. However, as this concept becomes more well known, it leads to the misconception that only Jews have BRCA mutations, which is incorrect and creates a barrier to prevention efforts in non-Jewish or non-white women. When we look at all of these ancestry groups and the different mutations, there was one study done where they actually showed that there are these many mutations in different ancestries, and some of them actually repeat. When we look at a whole bunch of these studies together, there was really a few outcomes that were found. And the main one is that BRCA pathogenic mutation prevalence is remarkably similar among women who undergo genetic testing, regardless of their ethnicity or ancestry. So with the exception of Ashkenazi Jews that we just talked about, they are, in most of the ethnicity and ancestry groups, there are about equal rates of people that are positive for hereditary cancer. So we have the same positive rate. And some studies even showed that African Americans had slightly higher rates, positive rates as well, which is not something that that people usually think about. Okay, so if all these ancestry groups are coming out with the same positive rate when we test them for hereditary cancer, then why is there a difference in the number of women receiving genetic testing in different racial or ethnic groups? And I think really when we think about this, there's a few different reasons. So one is this provider awareness and lack of referrals. So a lot of physicians or other providers may not understand that it is really important to refer everybody regardless of what group they're part of. There's also a difference in healthcare access and utilization of genetic services. There's a difference in different socioeconomic barriers and fear of just genetic discrimination, and maybe differences in medical literacy and trust in the medical system. And all of these really contribute to there being an imbalance in who really gets referred and then receives genetic counseling and genetic testing. So outside of the positive rate, there's also the other finding in many of these studies was a higher variant of uncertain significance, or VUS rate, in the less studied population. So what is a VUS? When we think about the human genome, there's no right or correct version of any gene. There's lots of variations among humans, which is what makes us all different. And since scientists have studied many people's genetic codes, we know that what versions are normal variation and which are not. And this is a general consensus of many people's genetic codes that the laboratories use as a reference. And anytime we find something different than what is expected, known, or common, it's called a genetic variant. If this new version of the gene doesn't change the end product, meaning it does the same job as the normal version, then it doesn't impact our health. And we call it a benign variant, which is just a less common normal version of the same gene. If this version of the gene creates a different end product, then it's called pathogenic. The word mutation refers to a pathogenic variant because it changes the function of the gene, which can go on to cause disease or differences. Many times we'll see a new version of a gene that we don't actually know what it does. We call this a variant of unknown or uncertain significance, or a VUS. And as we test more people, we learn more and more about the significance of these different versions of the same gene. And over time, as knowledge and technology improves, they may be reclassified, which is why it's important to test with a genetic counselor or genetic specialist who can keep you updated on these results. Now, if most of the people tested are from a specific genetic ancestry group, then the normal variations within that group will be better known and studied. And if somebody comes from a group that's less studied and the spectrum of normal genetic variants is less known, then the laboratory will call any of these normal variants that are less known a VUS. And so when we think about our genomic and genetic databases, 81% of these people in these databases and of these studies have been carried out in populations of European descent. And that's actually better than a few years ago, because a few years ago it was 96%, which means 4% that were not from these European ancestry groups. And this is not at all representative of the world's populations. It's very skewed towards European groups. And so this is a problem because it causes disparities. And so there's some things that we can do going forward. So we can create initiatives to foster careers of researchers from diverse backgrounds, hoping that there won't be as much kind of bias in the scientific community and there'll be more diversity. We can also help with limited engagement by kind of doing research on why these groups are not as engaged. We can look at why researchers have preferences towards European populations and incentivize research on diverse populations, which is actually going on a lot right now, and also figure out why there's difficulty of publishing, getting more diverse reviewers, and also why there's limitations in some of the technology and developing more technology that is helpful for all different groups of people. And then there's also looking into why there are challenges when we look at the genetics of certain populations. There's a lot of this is being done now, but there's more going forward and more needs to happen for us to really have genetics and medical genetics be equally helpful for everyone. So that brings me to the last question. I'm not white, can I still have a mutation? And I'm hoping that from watching this presentation, you now know the answer is yes, because people of all races, ethnicities, and ancestry groups can have hereditary cancer risk, and genetic testing can help you determine that risk. So if you want to keep in touch with us, we have started something called Black Cancer Genes, and we would love to now take any questions that you may have.